Welcome back, everyone. We'll get started this afternoon, so hopefully we can end a little early by 3. Okay. I know, before. If not before, Steve is telling me. Okay, so that those of you who are catching trains and planes and anything else can make sure you have plenty of time. We do have a couple of new people with us this afternoon, so we're not that large of a group. If we could do a quick introduction of ourselves again. This is the last time for 2 days, so if you've forgotten your name, hopefully you can remember. I'm Maeghan Gilmore with the National Association of Counties.
Leon Evans with Bexar County. I operate the Behavioral Health Authority in San Antonio.
Mike DuBose, COCHS.
Julia Kaiser, Burness Communications.
Donna Strugarf, Rich Health Management Associates.
I'm Pat Fleming. I'm Director of Salt Lake County Behavioral Health Services in Salt Lake City, Utah, both mental health and substance abuse, and I'm also the president of NACBID.
I'm Katie Bass. I'm with NACBID, the National Association of County Behavioral Health and Developmental Disability Directors.
Hello, I'm Ed Harrison with the National Commission on Correctional Health Care.
I'm Anita Cardwell from NACO.
Cynthia Summers with the New York City Health Department.
Cecilia Flaherty, New York City Health Department.
And Keith Parton with COCHS.
Ben Butler with COCHS.
Pat Ryan, Executive Director of the California Mental Health Directors Association, and our members manage the Medi-Cal specialty mental health system in California. And I'm Vice President of NACBID.
Nancy Torrey, COCHS.
Steve Rosenberg with COCHS. Ron.
Association for Community Affiliated Plans.
And Allison. Do you want to introduce yourself, Allison?
Allison?
Did we lose Allison?
Allison?
Yes, I'm here. Sorry, it's a little hard to hear you.
Can you introduce yourself?
Sure. This is Allison Hamblin. I am Director of Complex Populations at the Center for Healthcare Strategies in Princeton, New Jersey.
Great. Megan.
Great, thank you. And thank you for those of you that are logged on watching the webcast as well. This, for newcomers, this is the 4th of working group meetings we've had over the last couple of days, and we've taken a look at eligibility, workforce, and billing and medical records. And then to end today, we're going to talk about utilization review and quality. Just to give you a very brief background, kind of why we're here today, where we came from. The inmate exception has always been a long-standing priority for NACO. Well, long before those of us on staff who've been working on this, this has always been an issue for them, that the federal financial participation was not available for individuals once they are in jail. Now, I won't go into the termination versus suspension issue. I think we all understand that. But what opportunity we did have over the last few years was to insert language into the Affordable Care Act to address this issue so that individuals pending disposition would be a qualified individual for coverage on a plan. We have since then been exploring how that then connects with, and or if it does, or if we see that it might be an opportunity, connect that with Medicaid, not just plans on the exchange. And so our association, NACO, has support from the Public Welfare Foundation to take a look at this in more detail, to kind of educate our members and to explore these opportunities. And we've worked closely with COCHS, and Steve and Mike will talk about their work and activities in a moment. But we developed an internal working group at NACO of our members and some others to kind of help think through this. And I think what we learned just from those initial meetings and calls has been that there's a lot more to this, and there's a lot of other issues that we need to address. And so hence here we are with 4 other working groups to take a deeper dive into some of these issues so that we can kind of begin to clarify needs, as well as what our members may or may not need or want to do moving forward as we enter into 2014, so that there's some coordination within a county community of healthcare, and that includes the jail, not separate from the other providers. So with that, I will let Steve say a few opening remarks, and then I think Mike is going to talk a little bit as well.
Thanks. So I want to briefly review, Cynthia and Cecilia, what we've done for the past day and a half to bring you guys into the loop and express my appreciation for your showing up for this particular session. So we started off talking about eligibility and enrollment and the idea of a jail as a site to determine eligibility and enrollment and what were the issues involved in that. And you can see the previous discussions on the web if you want to sit through and follow them all. And then yesterday afternoon, we talked about the challenges of provider workforce. And while in New York, you guys have built a requirement into your contract that you have board-certified providers in the jail, that is extraordinarily anomalous in the rest of the United States. And so we talked about some of the challenges involved in the existing workforce as it is being accepted within health plans. We talked about some of the work that NCCHC has been doing in terms of developing certification requirements, or certification, not requirements, certification standards. Is that the right word, Ed? For docs who work in our nation's jails. We talked about what I call the scope of practice creep and the extent to which in most jails we have COs or EMTs doing assessments, although we call them screenings. We have mid-level practitioners running cardiovascular clinics, and we have a scope of practice situation in most jails which is not conformant with the community standard within health plans. This morning, we talked about how within a Medicaid paradigm, you have to be able to generate CPTs and ICD-9s, and we had some very lengthy discussion about how far away most jurisdictions are from those kinds of systems at this point, and what a steep hill it would be for jurisdictions to get up there. And we talked about outsourcing versus self-development and everything else. All of this comes within the context of a Medicaid termination or suspension paradigm that we exist in now. And as part of the work that COCHS has been doing with Attorney General Holder's staff and the President's Task Force on Reentry, Julia Kaiser from Burness was kind enough to do some background research that led us to believe that the system as it is may not withstand 2014. And with that, Mike, I'll ask you to set the stage for us, please.
Okay, so the fourth time is a charm. So as we approach 2014, there's some basic questions we need to kind of put on the table. One is what happens now to an individual with disability entitlements once they're incarcerated, and the basic questions about whether they are eligible for SSI, SSDI, and or Medicaid. Then the pursuing question then is what are the changes under healthcare reform 2014? And as Steve and Maeghan have indicated, we've been working with NACO to kind of try and develop some answers to those fundamental questions. Right now, the Personal Responsibility and Opportunity to Work Act authorizes Social Security Administration to enter into a reporting agreement with correctional facilities to notify them of the people that come into the jail that are on SSI. The jail doesn't know that they're on SSI, but the jail gives them an intake list, and then SSI bounces that list against their records to determine who's on SSI. Based on that, SSI then terminates that eligibility, and from that point, SSI notifies Medicaid that they have that person now, that person is now incarcerated, which results in their Medicaid coverage being terminated.
And it's actually not just the incarceration, it's the coupling, it's the no longer receiving the SSI or the SSDI that results in the state cutting them off in Medicaid in most circumstances.
And so since they're coupled, it results in the termination of the Medicaid benefits. But coming 2014, they will no longer be coupled. Medicaid will not be based on eligibility, but on income. And so the big question looming then is what's the relevance of SSA reporting to Medicaid, to the state Medicaid folks?
So I think the point we've been trying to make here, just to bring you all, Cynthia and Cecilia, into the loop, is while we don't know that come 2014, the same process of terminating or suspending will be in place, I think in New York, your counties actually report to the state who's incarcerated on an every 30-day basis, and that's how the Medicaid is suspended in New York. It's not done through SSA because you have this expansion population that's covered. It raises really interesting precedent issues, which, Maeghan, you may want to pay attention to. In NACO, that in New York, which is an expansion state, they're doing it through county self-reporting. The question would be, in other states, I don't know what they're doing in Minnesota, you might want to look at that. Other expansion states or Massachusetts, how the state gathers up that information if it's not coming from SSA, if SSA doesn't have the authority to transmit that for a non-SSI or non-SSDI beneficiary. So we just wanted to frame that. Again, we framed that before. With that, I think the last step in thinking through the process of Medicaid billing and what it means, assuming we have the providers and they're on the panel, assuming we have the ability to generate bills that have ICD-9s and CPTs, I think the remaining issues that we want to talk about are issues of quality assurance and utilization review. And I think, Ed, before I get into, no, I think I'll do my definitions first, and then I'm going to ask you to talk about CORDS and the work that you guys have been doing to try to define this within a jail frame. So let's first make sure everyone understands what we mean by utilization review. I think that's slide 7. Thank you. For those of you that are not familiar with it, utilization as a review is a process that's implemented by hospitals, insurance companies, and other types of plans that use explicit criteria to determine the medical necessity of a treatment or a healthcare services. It's critical to make sure that a service meets these criteria in order to be covered by reimbursement. This is very important to understand in a jail framework, as we'll talk about in a few minutes. We, generally speaking, don't have this, okay? Quality assurance is a mechanism through which the processes of how patients are treated and the outcomes of their treatment are assessed. What's important for those of you that don't know this to understand is, and I said this before the lunch break, is in jails, the sole issue on a tort is not malpractice or appropriateness of treatment. It's whether the jail was deliberately indifferent to the patient's condition. And in Estelle v. Gamble, which set the bar for determining the Eighth Amendment responsibility of jurisdictions to provide health care and correctional facilities, the Supreme Court specifically used the phrase deliberately indifferent. And so the system that we have right now judges quality and utilization on the standard of deliberate indifference. This is not the Medicaid or health plan standard, okay? Now, Ed Harrison at NCACHC has been working with a group of jurisdictions through the United States to try to determine whether there might be a way to develop correctional institutions specific appropriate standards for quality. And Ed, I'm going to ask you to talk about that just a little bit to provide us with background, if you would.
Thanks, Steve. For background, I'm going to go back a bit. I know you were going to ask me to talk about this, but I don't know where everyone is in the room in terms of their understanding historically. And I also wanted to correct a bit what you said, Steve. It's absolutely correct that the Supreme Court dealing with deliberate indifference is a huge issue for class action suits with in jails around the country. But malpractice also is still an issue.
An issue.
And so it's not that it doesn't exist at all. It can apply, but it doesn't raise it to the federal level. It becomes a state issue. NCCHC grew out of a project of the American Medical Association in the 1970s, prior to the Supreme Court decision, when it did a survey in conjunction with the American Bar Association of healthcare in jails and found that something like 85% of the jails in the country, and there was a good response to the survey at that time, the 85% only provided first aid as a form of formalized health care, and the majority of the remaining 15% didn't even provide that. So things have changed a lot in the last 30 years, and for those of you who have not had a chance to work more closely with the jails in your communities, currently there is excellent health care and excellent health care programs happening in a number of institutions. It remains challenging. There are numerous barriers, but there is a very good cadre of dedicated, qualified people providing care. For those of you who were here yesterday, I mentioned that healthcare is not the reason that most jails were built and most sheriffs were elected and that type of thing. It becomes part of their responsibility as they understand the federal implications and being good citizens. And there are certainly sheriffs and county administrators around the country who understand that the population that's in jails is part of the population of the community, and the fact that they're housed temporarily in a jail does not remove them as citizens of the community in terms of obligations once they are released. In an institutional environment, human nature is to make things routine. And the psychology is we have so many people coming in the door each day. Let's have a process established for making sure that they all get properly booked into the jail. There's a lot of nuances here and other things, but generally this is what happens. And the same is true with health care. Health care in an institutional environment, a nursing home, VA hospital, or in corrections, you have so many patients that you need to see a day. There's jail detainees will put in a sick call request slip, typically, and that'll be triaged by somebody, hopefully a nurse, and whether or not the person needs to go on to a higher level of being seen is determined at that time. But the issue often is, well, I have this caseload for today, and by the end of the day, I have to get this stack down to here. I have to be able to see my desk. And that mindset, that human nature of trying to work through all these people that need to be seen, sometimes the goal becomes getting through the stack rather than the quality of care that the person is getting. And we often see people saying, I saw X number of patients today, and my goal was to get to X number of patients. And NCCHC, which started back again when healthcare in jails was not very organized and not very well established, began to see that more and more emphasis ought to be placed on quality outcomes rather than the quantity of people that were being seen or the quantity of care that was given, other processes. In the late 90s, Congress asked us to do a report on the health status of soon-to-be-released inmates. We all know that the status of someone who's going to be released, their health status of someone who's going to be released tomorrow might not be much different than someone who's going to be released in 2 weeks or 2 months or in a year. But I think it was framed soon to be released inmates so that the emphasis in Congress and the public and in the research is what impact is this cadre potentially going to have on the community. We found, among other things, that many sites really didn't know the extent of disease in their jails. If there's one thing that you'd think jails could do pretty well, it would be to count, and they do a good job of counting, and they'll count inmates on, 2 or 3 times a day or more. But when we started to look at things like the number of diabetics, and asked how many diabetics were behind bars, and we asked the jail administrator, you asked the medical director, and then you go to the pharmacy, and you get 3 different answers. And so we thought that it was about time to organize a more systematic approach to identifying and treating those with chronic diseases. And again, as I mentioned the other day, chronic diseases, while not necessarily the most common diseases in the jail, they often come with the greatest risk for the jail of a bad outcome, bad publicity, lawsuits, and other things. About 4 or 5 years ago, the RAND organization did a study of prison healthcare systems and found also that there was no standardized methodology for identifying serious diseases and the level to which those patients are in need of care. Assuming that we know how many diabetics are in our system, are they in good control of their disease, or are they not in good control? Are they in need of some adjustment? And the CORDS project, CORD stands for Correctional Health Outcomes Resource Data Set, is the first attempt to get some standard definitions on disease and the control of disease and some measures similar to what HEDIS has done in the community, if you're familiar with the HEDIS measures. Robert Wood Johnson has a project for getting community health providers to share outcomes data for the betterment of the healthcare of those individuals participating in that community, and apparently one of the stories I was told is that community providers, it was very difficult to get people to participate in the program. People are afraid of sharing data, that it might cause embarrassment, that there might be some confidentiality that's breached. And it's expensive and somewhat complicated, the way it's done in a number of community settings, such that people question, is the squeeze worth the juice that we're going to get at the end? The groups of people that we've been talking to have been relatively enthusiastic about participating in an opportunity to define what the measures ought to be and share that and share their outcomes in treating patients that fit those criteria with others. It would have to be anonymous, but the initial participation has been very strong, and so there are a number of sites representing hundreds of thousands of inmate patients that have agreed to participate, and we're working through the process now. We have a template for reporting. We have agreements to be signed for confidentiality and for other things, and we're very excited about sort of changing the mindset from how many patients are being seen to how well they're being treated based on standardized measures, which again heretofore have not existed, and sharing that data among the group so that they can assess how well they're doing, how one county does compared to another county, how one jail, another jail, one prison to a different prison. And I think as the program goes along, we're going to be able to slice and dice the data so that we'll get pretty good demographic comparisons. And it's a quality improvement. In our case, I wouldn't refer to it as quality assurance, but it's a quality improvement effort. And we talk about CQI, continuous quality improvement, on the theory that we could always do better. And the place to start those, you do better at what you're being measured on, and the CORDS is a good effort to get that started.
Thanks, Ed. I want to thank you and NCHC for both your leadership in this and for your efforts. in bringing this discussion to bear within the county jail system. I know you've had an uphill issue in terms of bringing folks' attention and efforts into it, and we're very appreciative of that because I think that we share a common goal of increasing the quality and assuring community standards to the extent that we can in jails. I want to go back to a metaphor you used, which I think is a really valuable metaphor for us to use for the rest of our discussion this afternoon, and that was the metaphor of getting through the stack. And if you think about how we've developed utilization review and quality assurance standards in nursing homes, in hospitals, in health plans, what we've done is we have defined a set of processes and metrics that govern how we go through the stack, okay? And these are not simply outcome measures, these are frequently process measures, going back to the definition that I put on the board of utilization review and quality assurance, that govern how we go through the stack. Because jails up until now have been a totally unregulated environment, and other than a jail seeking NCCHC or ACA accreditation, there's nobody actually looking at how that jail does business. The challenge in thinking about Medicaid billing and Medicaid collections and health plan participation within a jail isn't only the issues of providers and systems to do CPTs and ICD-9s that we've discussed. You can outsource, as Pat mentioned, the ability to do CPTs and ICD-9s. What each institution would need to develop on its own that would be subject to review would be the process of going through the stack. And both the process of going through that stack and the expected outcomes that would come from going through that stack would then be externally measured and reviewed in both the health plan environment and or a state Medicaid environment, depending upon the scenario that you act in. And just as this morning's session concentrated on is the hill too steep for jails to develop systems that involve recording CPTs and coding ICD-9s, I think I'd like to frame the question this afternoon is that process of building a different system of going through that stack, is that too steep of a hill? And then I want to couple that question with, Kathy, part of what we talked about, I guess it was yesterday afternoon, in this discussion about providers, on this whole question of report cards. And so, as we move to a more of a consumer-directed and consumer-selected healthcare system, part of what we're doing is we're thinking about a report card as a mechanism of giving consumers information and choice about what health system to select. And we are developing various metrics, all of which can be framed within Ed's brilliant metaphor of going through that stack. Who goes through that stack? How do they go through that stack? What are the expected outcomes from going through that stack? Do I have measurements to go through that stack? And we are building various outcomes that we turn into report cards on which consumers are supposed to make decisions about where their health care is purchased or purchased on their behalf by a public entity. And so I'm really posing two questions. One question is an internal question. Is the hill too steep, or just how steep it is, for jails to figure out how they build systems that go through that stack in a way that are measured and accountable? And then the other one is, how would those systems interface with the report card paradigm that we are shifting to, which Kathy drew our attention to yesterday in the discussion on board-certified personnel within a jail? And I think I'd like to start by throwing those two questions out on the table for folks to start helping me think through. Pat?
Be quiet this afternoon.
Aha. Well, but you guys have been going through that stack on the behavioral health side.
Yeah.
Right?
Yeah. The difficulty we have right now is that our sheriff is actually running the mental health system inside of the jail. We're running the substance abuse side. We contract and do that. And what happens is the provider I have in the jail uses my electronic health record, which is not the same electronic health record as the sheriff's.
Gotta love it.
Yeah. So one of the things that we have tried to do, because there are so many separate IT systems that are out there, we've tried to come back and look at this thing more holistically, and we've developed this thing called, and it's very common across the country, Integrated Justice Information System, where we have all of the various systems. Our goal is to have them actually talking to each other, which would include the Medicaid eligibility system, would include the court system, would include the probation system, the sheriff's jail management system, our system, Optum Health system, and all linked together to talk to one another. As far as I know right now, ours is the only one that actually does billing, and that has a complete record that you could actually do some quality assurance and quality review on electronically. I don't know if the other systems have that at this point, but that's kind of what our goal is right now, and we actually got a project going on. We're trying to move towards that, so because we recognize that is really the key.
So
that whole thing.
I heard you say a couple things. One is the sheriffs own the system. This goes back to our conversation this morning about how sheriffs own the medical records, right? The sheriffs own this system. It is their system, okay? It is not their healthcare provider system. It is maybe under contract portions of it delegated, but it's still their system. That there's, I think, Ed, you talked about it yesterday, that sheriffs are not running these jails for the purposes of providing health care or determining eligibility of Medicaid beneficiaries. They're running these systems in order to assure public safety. That in general, the sheriffs run fiefdoms or small little empires that they have on their own without a lot of oversight to begin with, let alone the kind of oversight that we're discussing would be necessary for UR and QA. And I don't see how you can have a Medicaid billing system that, separate from everything else we've talked about, providers, CPTs, ICD-9s, that doesn't have utilization review and quality assurance built into it. And unfortunately, the closest most sheriffs have to that is a grievance system in their jail, in which somebody grieves and said, I've put in 3 sick calls and I haven't been seen by a nurse yet. That's the closest someone has to making sure that the stack has gone through in an appropriate fashion. That's not going to work within the new environment we're talking about. Yeah, Donna.
Well, there's the voluntary accreditation, right?
Right, that's what Ed does.
Right. And there, correct me if I'm wrong, but don't most states regulate jails?
Nope. Nope, not at all.
Some do.
Some do. New York State does. That's an exception rather than the rule.
We don't.
Some have jail standards commissions. In
right.
New Jersey, there's no oversight whatsoever. You've seen one state, you've seen one state.
The rotation varies from state to state.
Right.
It might be annual, could be biannual. I mean, every
right.
2 years.
Right. So there are those. There's also, I know that you've said that deliberate indifference is the only standard,
Is a federal standard.
Well, right, but there, to my knowledge, there's an expectation that care is provided at least in some fashion similar to the community standard, which is what the accreditation process, partly what the accreditation process looks at. On the prison side, it's unthinkable that there wouldn't be a utilization management and a quality improvement program.
Right, but it's not true in jails. That's what I'm trying to educate folks on. Mike, go ahead.
Ed, how many jails you got accredited? NCCHC? 500 out of 3,300.
And some are ACA accredited as well.
Some could be.
Yeah, but a different standard, though.
But when you're talking about 3,300, most of the jails in the country are quite small.
Right.
Maybe 50 beds or even fewer. So
1,500 or more, we're talking about what kind of number?
Oh, I'm not sure, but once you get up around 750, 1,000, that's a good-sized jail with full-time staff.
Right. And a large majority of those jails are not accredited. And so there's a range of what's provided in those jails, from Cadillac to that broken down Volkswagen.
meeting jail standards for?
Well, there's two. The ACA one is jail standards. Ed's accreditation is healthcare specific, but I was going to say your accreditation doesn't really have what I would call, in a standard way that we think about QA and UR, the criteria for going through the stack. It has expectations about how quickly you're supposed to go through the stack. It has expectations about when a person is supposed to be seen by. So it has a different set of ways of thinking about processing that stack than we would think about within a Medicaid context.
But there's requirements as well for what a quality assurance program has to look like and operate. And
let me. The standards cover both processes and outcomes.
Right.
It is not what you'd find in a community setting in terms of the processes for dealing with Medicaid and Medicare, but it could be adapted to that in time if that's the way the nation is going. But it is intended to be helpful to those sites that wish to improve, as opposed to, it's not designed as a reimbursement quality check to see if XYZ is taking place and therefore we're going to pay you. NCCHC happens to be an accrediting body for opioid treatment programs as well from SAMHSA, so we understand creating an accrediting process to meet federal regulations. But the accreditation we've been talking about, has not been one to meet federal regulations, other than at a minimum the Supreme Court dictum.
Not that you couldn't. Let's be clear. There's no reason you couldn't develop that as part of your standards. But I would say there's been no market pressure to develop that as part of your standards, is how I would frame that.
Well, I think the focus has been trying to help people improve.
Right.
And, we're sort of dedicated to that as part of our mission, to help people improve healthcare. As time goes on, over the past 30 years, we've seen all sorts of improvement.
Right.
We can extend that elsewhere.
Including those places that are not officially accredited, but that buy the standards books
and
build their programs to it without paying for the survey.
Sure.
Which is, the standards are out there they are the industry standards.
That's correct.
They are the industry standards.
I was also going to say, Steve,
whether you're accredited or not, I think there is a standard of care that this organization has established as a floor, wouldn't you?
And they're often brought into play in court cases. So you were talking earlier about the Supreme Court, malpractice, and other things. And so another sort of quality assurance mechanism that's out there is the ability to suit in federal court for deliberate indifference to the serious health needs of inmates. They're one of the few classes, maybe only one of two classes of
Native Americans and
citizens.
Jail.
I was thinking of the military as well.
Right.
That are guaranteed health care under the existing system. So
add Native Americans under treaty. That's your third.
And as you know, here in D.C., the federal courts at one point thought that the health care was such that they had to put a receiver in place.
There are many places where we have that. Right.
And D.C. is an example.
Right.
And so that is part of, in a sense, the quality assurance process that's available out there. It's an extreme, but it's part of the spectrum.
In some ways, I think the question of whether the lift is too big or the hill is too steep, it goes back to your thing when you've looked at one state or when you've looked at one jail, you've looked at one. It depends on where people are in the process and how far along they've gotten, but in some ways, the question right now is, will potential changes like the potential ability to bill Medicaid in jail be enough of a market driver to get people there? Because up until now, unless it's just been a mission-driven, it's the right thing to do, there's been no incentive in place to get to any kind of standards if you don't have to, especially in jurisdictions where healthcare in the jail is run by not a healthcare agency. I mean, I recognize that New York is rare in that it's the health department actually that is responsible for healthcare of our inmates. In most states, that's Department of Corrections, and clearly correctional departments versus health departments have very different missions. But if you look at the revenue potential, even if it's a steep hill, I mean, it seems to me that that's going to push people to make that investment, whatever that is, or at least seriously consider it.
So I think that's a really good point. I think the query that I'm trying to pose, and I want to go back to posing it clearly, is I think Pat talked this morning about how you can outsource systems to do CPTs and ICD-9s. You really can't outsource a system to do quality assurance in UR. That's a system that you yourself have to develop and have to monitor, and that's not something that you can outsource. And so if part of our conversation has been what is the burden on counties to prepare for 2014 should pending disposition come to place, I think that's the question we want to pose. Yeah, go ahead, Kathy.
I think I would differ a little bit on the issue of whether or not you can actually outsource the quality assurance measurement function.
Measurements,
you
right.
definitely can, and you can probably even outsource the correction of what you find if you have the support of the correctional facility or the jail or wherever you are to implement things. But I mean, there's no question that the individuals who are actually providing the care have to be willing to make those changes. But I think you can outsource the reviews.
Sorry, I wasn't saying this clearly. That's what I'm.
Okay.
That the process of how you go through that stack. Let me go back to Ed's metaphor. There's that the process of how you go through that stack. That's a system that has to be developed and re-engineered by the jail. You can hire a consultant to make recommendations. You can do all that, but at the end of the day, that's not an outsourced function. That's an in-house function, whether you contract it out, whether you provide it directly, whatever your burden is. The question is how you go through that stack. And the point I'm trying to make is, for those of us who are exposed to jails on a regular basis, the gap between how we go through that stack right now and how we would have to go through that stack within a Medicaid framework is very large. It's a very large gap, right? And I can't outsource the fill, if you guys hear what I'm saying. And so I think the query I'm making, and I appreciate what you're saying, Sonny, but the query I'm making is no matter how many resources are there, we've identified that the resources aren't going to suddenly enable me to find board-certified docs who are going to work in my jail, which is not the current workforce that I typically have. The resources aren't necessarily going to enable me to do things in a different way that I've had them. And so the question I'm trying to pose is, I said the first question is this: how do you go through the stack? Then the second question goes to the relationship between who and how and what the outcomes are going through the stack, and report cards. Okay, so there's really two issues. I think if you get a bad report card, Kathy, you can hire someone to help you figure out how to improve your report card. But if that report card is, for example, based on percentage of board-certified personnel, and you can't detract board-certified personnel, what do you do to improve that report card? If that report card is based on, a certain number of folks having their blood sugar checked, and you can't incorporate blood sugar checking into your stack because you have lots of resistance all over the place, how do you improve on that? I think that's what I'm trying to pose. Again, Cynthia and Cecilia, part of what we've been saying is the function of these working groups is to help give NACO information for them to take back to their membership and electeds, to help their membership and electeds think through how complex this holy grail of ending the inmate exception and harmonizing the language in PPACA on the exchange with Medicaid. And now that we have that possibility, the devil is always in the details, and what do these details look like? Yeah, go ahead.
New York City has some of these things starting to happen. Not all of our doctors are board certified, but we're moving towards that in the New York City jail system. And we do have, but it's not on the scale of what we need, we do have a separate quality assurance group of nurses called our Service Delivery Audit Unit. It's 10 nurses who full-time just look through paper charts and our electronic medical record to audit our contract healthcare provider, but it's, you know, on a different size scale, but they spend full-time just managing our performance indicators.
How many jails?
There's 11 jails in New York City. 13,000 on a given day. So they go through, I mean, they use, you know, statistically relevant numbers to go through the PI, so I think it's like 211 charts, depending on the measurement or outcome that they're looking at, that they look at on
More importantly, what you guys have done is you've defined performance indicator. You've done something more important, which you're leaving out because it's self-evident for you. You've defined the performance indicators and performance measures against which those nurses look.
Yes, but those are all changing too, with the ACA and other things, and looking towards getting at meaningful use. We're starting to reshift more like population health focused indicators rather than did you get your test done in this number of days too. You know, there's
but the crucial point I want to make is that you guys set criteria on which you could gauge how you went through the stack. Okay.
Yeah, and I would. Yeah, and I was going to say that is the one thing that I think, as much as this group and others can help jail systems do, is that because jail providers and systems have been so siloed from the rest of the provider and healthcare system, I think it won't be obvious the need to, even if it's harder, to go with what the national standards are and what the national uniform measures are, because as we move towards you know, health insurance exchanges and meaningful use and all these different areas, health homes and the need to integrate, and hopefully even in all the jails getting to an electronic health record that's able to talk to other health records and RIOs. Like, we need to all be holding ourselves or measuring ourselves based on the same standards, even if the requirements or the bar varies depending on the setting. I think sometimes it's not realistic to say that a jail population has to be held to the same standard as the community population, and I think those kinds of adjustments can be made, but we all need to be measuring with the same stick.
So I'm hearing you say several things, and I want to tease that out. Okay. So one, I would say, I'm hearing you say in New York, because it's the Department of Health and not the Department of Corrections that has this responsibility, you had a motivation to develop a measuring stick. Okay. The question becomes where both. But again, it was the Department of Health that was doing that. The question becomes, if it's the Department of Corrections, if it's a sheriff, what's their motivation for developing a measuring stick other than the measuring stick that either ACA or NCHC provides them with? So that's one question. The one issue I want to put out on the table. You have a specific motivation. The other issue I want to put out on the table, which I want to get back to in a second, is this issue that I just heard you say, Cynthia, about maybe we can't hold folks to the same standards in the jail and in the community, but I'll get back there in a second. Pat?
I was going to say, Steve, I think it's pretty interesting because where they are, so if the goal is a fully integrated jail health system, where you've got, you build insurance exchanges and Medicaid and everything, at this level, it sounds like New York City is right here because you've got your health department. You're running a health service. A lot of us are down here, right? So the question I have is, how do you work with your sheriff? I mean, he's responsible, or whoever. I don't even know what you call him, but whoever jails. How do you work with them? Because their responsibility is safety, making sure that they're managing security. How do you do that?
And that's some of the same issues that I think all the other jurisdictions deal with, as far as security being paramount. We still deal with that. I mean, healthcare comes second to them, or third or fourth, and they think of us as a nuisance for a large part.
The tough part is that we live and operate in their house, right? Because we're doing our service that we happen to be responsible for, but we're doing it in their jail.
In their jail.
And so there are struggles all the time, and we could have a 2-day conference about
Sure.
that, about, when we know
could.
that there have to be changes to ensure the health and health safety of our patients who are there. A lot of times those changes rely on the cooperation of Department of Correction, and that does not always go very smoothly.
And New York is also a little unique on the scale too, because we suspend Medicaid and we help individuals enroll in Medicaid who are not currently on Medicaid. But obviously we can't cover those services in jail, but there is sort of that piece that we have going.
But you also left out the crucial difference in New York. The Department of Corrections, the Department of Health both report to the same person. In the mayor of New York City.
In theory, yes.
In most jurisdictions,
and we share the same.
In most jurisdictions, the people who run the jail are the sheriff, who are publicly elected, okay, and the county health services report to the county commissioners, which are separately elected.
Yep.
So if you think you all have a set of challenges in New York in dealing with this, at least in theory, everybody reports to the same boss.
I have a question. I wanted to get back, and Megan, I know, and others here have written a lot about the exchanges and what's going to happen with detained individuals. So all of the UR, and QA that Steve is talking about, how does that, I don't know a lot about qualified health plans and how they have to meet standards that are similar to Medicaid.
Same thing.
So we know that's moving forth regardless of whether we're ever able to bill for Medicaid. We assume that we are going to be able to bill for pretrial detainees who fall into qualified health plans once they're incarcerated?
That's correct.
So all these things are going to be moving regardless of
That's
whether...
correct. And I think the question goes back to money and volume. I think you said it accurately before that, if we look at the national data, it says about a third of my pretrial detainees are above 138% of poverty, and about 2/3 of them are below 138% of poverty. So I can figure out about a third of them are going to be in the exchange. I need to do an analysis on what that really means in terms of dollars. But I want to go back, Cynthia, to what you said, and Kathy, I'm going to ask you this question so you can give me this comment when I ask you this question, which is, how do you feel about having one set of grades for the population in jail and another set of grades for the rest of the community? And how do you report that in such a way that I, as a consumer, know whether I want to choose your health plan or another health plan? So I'll let you make your comment.
Question?
Yes, ma'am.
Because we actually talked about this at lunch a little bit, and so as a representative of plans that are very involved in providing services to the safety net population, of which many of these people will be part of, I mean, I think we would like the services to all meet the same standard. I mean, I think that's very important. But to the extent that that is not going to be possible from a plan perspective, I don't think I would imagine, without having talked to a lot of our plans, that they're not going to want to be held to a standard that includes what goes on in jails and prisons if they have no control over it and no control over how the services are delivered, or if security is going to limit, I'm sorry, today you can't go have whatever test because we're in lockdown kind of issues. So we talked a little bit about this yesterday. Can we have two standards? I mean, perhaps we need to. And and then I don't know whether you even measure the plans on that service, or whether you just exclude it.
But
I don't know.
If I think about how this all works in terms of data aggregation, in terms of this great big system we're talking about building, what's going to happen, at least in theory, is I'm going to aggregate your grades. Yes, ma'am. Go ahead.
Because I have a question even before that, because having now moved from an extraordinarily wonderful managed care organization and now having basically an indemnity plan, because I'm a former New York State employee who no longer lives in New York State, I've discovered a little issue called basically the place of service. So, I go to my physician and they tell me to do this, and I walk next door and I get the shot, and surprise, my insurance company says, oh, we don't cover that because that's not an approved place of service.
Right.
So I don't know whether jails will be ever considered an approved place of service. I think it's a whole other issue that we need to think about.
I know you guys have written as if they will be, right?
But I don't know that they will be.
Well, even if
Megan?
even if plans,
I think what we were looking at is trying to interpret what was in the law. And so we do have a legal memorandum, which if you haven't seen, I can get for you, but we also can have that, we can send that to you. I don't think that's on our website, just our comments are. So, you know, we're trying to make this crosswalk to Medicaid, and I think that's still a question of whether that will be or not.
Crossover, understood, but just even the qualified health plan enrollment, if someone gets detained, what happens to those healthcare services in jail while they're in the qualified health plan?
those are commercial plans.
Yeah.
And what occurred to me that two words we haven't talked about in the last 2 days is prior authorization. So, you know, even if you are somehow impaneled with this plan and your providers are approved, chances are whatever you do that you want to get billed for, because you're on the edge or outside of the circle, you're going to have to get prior authorization for, which is going to be a gigantic barrier that would be very easy for the plans to throw
The jail
up.
provider would now need to be prior.
So you'd have to call ahead before you
get locked
unless
up.
you're impaneled. If
well,
you're a PCP
but you may
that's
even
impaneled.
still need to do it by service to
By
say
service.
this
But we don't provide a lot.
dialysis session.
Yeah, we don't provide a
is
lot of those
approved
services.
for billing
We don't
ahead of
provide.
time.
But Donna, we don't. A lot of those services you're talking about are just not provided in jails.
Dialysis.
We provide dialysis.
Well, yeah, that's again. You guys are the exception. Yeah, Flo.
Glucose. I mean, everything that you want to bill for can be prior auth.
Right. Go ahead, Flo.
I was going to kind of say the same thing. A jail would conceivably be doing services for more than one plan.
Right.
So each with different sets of requirements. But
How are they going to manage that?
well, that's part of this question. But for instance, in our state, where even Medicaid is entirely managed, everything, the provider itself has to have these systems to self-monitor, but then there's going to be complete external utilization, management, monitoring, accreditation requirements of certain kinds of accreditors, which I think yours is one in our state, but there's just going to be lots and lots of different standards. Just like a health practice may have to be billing 10 different plans and know all the rules for each.
Yes, and I think the prior auth, Donna, takes me to a really fascinating question, which is when the prior auth is requested, I'm going to ask to see X test, Y test, and Z test before I do the authorization. Sometimes, and is X test, Y test, and Z test done? And that takes me back to my process of going through the stack. That what happens within a more traditional primary care setting, that as I get used to flow working with multiple insurance companies, I build a process of going through that stack that diminishes my likelihood of my prior auth being rejected. Okay, so I understand as I build my process of going through that stack what what I would say is the external expectations are, and going back to a jail setting, that's what we haven't had. We haven't had this set of external expectations about how we go through the stack. You have it in prisons. You generally don't have it in jails. And I think that, to me, gets down to the really interesting question that even if pending disposition you are correct, I don't know if Cynthia, you mentioned this, even if it only applies to the exchange, you're still going to have an externally signed off on procedure for how you go through that stack. And in New York, you're probably further along than anywhere else in the country, okay, on building those workflows and understanding how you go through that stack. And you guys are still climbing up that hill all the time. Yeah, go ahead, Cynthia.
I mean,
And then
stepping
Kathy.
back, there's going to be a lot of really complicated details to work out with all of this, right? And I don't know how many plans most states or counties have. We have in New York City way too many. But I mean, I think in some ways we have to think about, since this is new for everyone, right? And
Right.
I think we can all agree, plans, health departments, jails, et cetera, that when someone is incarcerated, they don't have the choice of picking this provider or picking that provider because they're there. And I think we could also agree that to deny necessary care costs everyone money, and it's bad things. So in some ways, I mean, I think we have to try to think about ways to convene the health plans and the other stakeholders, the jails, the health department, whoever that is, beforehand, and see if we can agree to a way to do that. If all the plans have different requirements and different this and different that, if we can say, you know, well, when there's a provider who's in jail, there's some kind of code that we assign to that, and we know that, you know, and there may be exceptions for extraordinarily, you know, for an MRI or for things like that, you still need prior authorization, but for general, I mean, I don't know that it's going to work everywhere, but I know that in New York City, for certain things, we've successfully done that when things have come up.
Your data and certain things, you don't want a prior auth anymore because it costs you more to prior auth them than to.
And maybe in a jail setting, even things that you normally might do that for, people can agree, especially if you get everyone around the same table and say, look, we're all going to be in the same boat. Now with health insurance exchanges, someone goes to jail, regardless of whose plan they're in, this is going to be an issue, and we have to figure out how to solve it.
And we're dealing with in New York City, I know different states are in different plans with health homes, but we're now, as of February 1, rolling out health homes in 2 of our 5 boroughs, and the other 3 are rolling out in a few months. So we're dealing like head on with like how are health homes working with the ACA and everything else, because that's all Medicaid focused, and they've kind of left the jail world off of the map.
We're working on it, as you know.
Yeah, I mean, we're working closely with the state to address that, but it's...
Yeah, Kathy, you had your hand up, and then Donna. Okay.
What I was going to say.
So I'm going to turn this on its head and say that it's within the corrections system that the strictest utilization management already occurs. It's just unrecognized and uncounted because those systems have the financial incentives to only do what's necessary because it's not a fee-for-service reimbursement environment. And because it's a budgetary issue, it's public money being spent, and the public doesn't like inmates getting better care than they get. So when we've looked at prison data, I'll give you that, but I don't think it would be different for jails, at the standard measures, HEDIS measures for diabetics, the incarcerated population blows off the charts because, of course, you can do their hemoglobin A1Cs when you're supposed to because you can go get them. And so the quality indicators that are measurable in a corrections setting that we've looked at are exceptional. We looked at ambulatory care sensitive hospital admissions and emergency room visits, off the charts low, because all the incentives are there to not take a person to the hospital for an asthma condition or for a viral pneumonia. So on one hand, the prisons and the jails can say, we are managed care, and we are population-based, and we don't have registries, we don't have good EMRs, but if you need to see how many MRIs we do per 1,000, you'll be shocked at how few they are. So I just want to bring that up because it's a powerful tool that doesn't get talked about. People think that, you know, the community providers may think that prison health care is a black hole, but it's actually a tightly managed system, and I don't think that we should overlook that.
I think that's definitely true for prisons. I think within a jail setting, the forces are different, and I just want to go through the different forces. Part of it is the rapid turnover within a jail. Part of it is the extent to which people are, by the time they're in prison, they're sober, they've been detoxed. Within a jail setting, you know, the ADAM data says jurisdictionally between 2/3 and 4/5 of the people that are admitted to a county jail or have an illegal drug in their body at the time of arrest.
But that doesn't mean they're going to get MRIs.
No, but what I'm saying is that the challenge of how that is managed. So the great debate in jails, for example, is kit versus medication-assisted detox, okay? And how that is managed. And so one would argue, if I go down your line, that because kick kits are more expensive, are less expensive, that kick kits should be the standard of care that we use in a jail system in terms of a QR and UM. Dr. Barton would strongly disagree with that. So I think that the question is because the presentation of folks in jail is very different than the presentation of folks in prison, because the turnover is much quicker in jail than it is in prison. It's very hard to take a set of metrics of the type you're talking about and decide they apply to a jail which doesn't really have a stable population base on which you can evaluate it. I'll have a small number of folks that are staying for a while, but it depends on court turnover. You know, in Cook County, if I'm 9 months for adjudication, am I still 9 months for adjudication? If I'm 9 months for adjudication in Cook County, I'm going to have a more stable flow. Yes, Cecilia.
Yeah, I mean, there's truth to both of those things. In New York City, which is all I can speak for, we do have a captive audience, but half the population is gone in a week to 2 weeks. So what you can follow up on is slightly different. So you might have a much shorter window, but we're looking at that at courts too, how we look in jail jurisdictions versus prisons as far as trying to set standards that sort of meet those time frames a little bit more.
So what services exactly do you think you'd be billing for besides detox?
Well, we do a full medical history and physical when people come in within the first 24 hours. We provide all STD testing. We offer and provide, HIV, chlamydia, gonorrhea, syphilis testing and treatment.
We do an A1C on everyone, right?
Yeah, we do A1Cs. We provide all of the medications that people need. Sorry.
That if you had an electronic health record or
We
medical
do.
record,
An electronic health record.
that was connected out to the Rio, so you would know whether person X already had all those things. So you're probably
that's
not
exactly
connected.
why
We're building all of
We
those.
we're again in New York, I think ahead of the game that way. Like we're ready with our EHR to upload to the Rios now. The Rios aren't ready to take it entirely, but I mean that's our hope. And then the other thing, we've been working with the state to try and get access to their psyches database, which would allow us for mentally ill patients when we come in to be able to see their treatment and meds records when they come in, because one of the things that is not uncommon is that someone comes in completely psychotic and you have no idea. You don't know what meds they've been on. You don't know what's going on. You don't know what. So we spend a lot of unnecessary money retesting for things, doing things like that. But also the flip side of that, why I think there's some incentive for other providers to get on board with that, is then all the providers in the community redo the same thing, because when they see one of our patients when they're released, they don't know what happened. They don't know all of those results. But that for us will change.
So I have a question to the other very concretely. Let's assume for the moment that you're hooked up to the Rio. Do you think that will change? You're doing an H&P on everybody within 24 hours?
Probably not.
Maybe some of the components of it. I'm not sure.
But I would suggest that maybe fewer labs.
Right, exactly.
Definitely
Right,
fewer
but
labs.
fewer labs. But I would suggest that you're still going to do an H&P on everybody within 24 hours. It might be briefer. You might order
would think
fewer
so,
labs.
yeah.
But I think, going back to your question, Donna, what would they bill for? I think that, and how many people go through Rikers in a year?
About last year was, I think, 80 to 85,000.
Right. So I think you start seeing some of the scale of billing opportunities in an environment like Rikers, where I'm doing an H&P on everyone within 24 hours. Kathy?
So speaking from a plan perspective,
Mm-hmm.
I would, if the plan is just paid for a full workup on somebody for an annual physical, and then 3 weeks later they end up in Rikers and they do another one, it's not medically necessary, and it's
Institutional.
right. It's definitively institutionally necessary, absolutely. But I would think the plan would be reluctant to.
Yeah, it moves forward the whole idea of information exchange
right.
being that much more important.
And then the other thing, you're talking about Rikers and New York City having to deal with a myriad number of plans, managed care or otherwise, in New York City. But there are a lot of health plans that cover many, many jurisdictions. So thinking about it from a plan or insurance company perspective, if you have to be able, if you cover pick Texas as an example, which may or be a bad, but you know, there are 250 counties in Texas, 250 plus counties. If you have to deal with, you know, 25 or 40 different county jails, and you have to figure out where each one of them is, and that's as daunting on the plan and insurance company side as it is on the jail side.
We've posed that question to the state regarding health homes since they're rolling out. How are you going to know where this person is located tomorrow and the next day? Because they might be in jail the next day. And how are you going to manage their care when they're moving in and out of the system? And their date of release is likely unknown because they're a pretrial detainee and they might be gone next Monday. And who's going to connect them to care? And how is that all integrated with those Medicaid providers?
So part of what I'm hearing you say, which I want to elicit it up in Braille, is that let's assume for the moment it's April 1st, 2014. This is a pretrial detainee who is in the exchange. The exchange has given that person a premium subsidy to participate in an ACAP health plan. That person saw their practitioner in February, okay? It's now April 1st and that person has been jailed. Even if you all know that that individual was seen in February because you're now part of this brave new world of Rios, are you guys going to do an H&P? Are you going to expect to be paid for it by Kathy's plan? I'm just trying to drill down here into very specifics.
I'm not a clinician, so I probably can't be the best one to answer that question.
We have one at the table who's worked in a jail. Go ahead.
But I will say that when we get to the point where one arguably has real-time or close enough to real-time access to that person's medical record, right? Mm-hmm. If, you know, Cecilia comes into jail and I'm the intake provider who's seeing her, and I can see 2 months ago she had a full physical, she was in good health, this and this and this, and there's no...
That's not your jail population.
No, it's not. But
so let's go to who your jail population is, okay?
But if I'm, you know, if I'm seeing that, I don't know. Maybe we would not. I imagine there's always some kind of screen that you have to have.
Different
okay, so Dr. Barton, I want to put you on the spot, okay? There's a 26-year-old heroin addict who is in jail for the 4th time in 18 months. You look on the Rio, this person, that's a male, had an H&P 2 months ago. Do you want to have a medical provider in the jail, and this person has a bunch of priors, they're likely to be there for a while, they're not likely to bail out. Do you want this person to have an H&P within 24 hours?
Is the person intoxicated?
Yes.
Then yes.
Why is that?
Because you're likely you could be missing something if they're not able to give a reliable history.
And even if you could see that history on the Rio, would you still want on their electronic medical record in the community?
Well, you're worried about pneumonia or something else happening.
Right. So I think, Kathy, this is that again we get back to who's in jail. Okay.
That we house people based on their state of, you know, their current state as of this moment.
Right.
So you need to know a series
and so I want to go back to my question of who's in jail. Okay. These are generally young men, generally of color. They're generally substance abusers. They're generally intoxicated at their point of admission. Yeah, Cynthia.
So I have another question that's sort of a parallel, and I just don't know the answer to it from a plan's perspective. If I'm that same 26-year-old heroin addict,
if you were not.
If I am that same,
yes.
I don't end up in jail, but I end up in the ER because, for whatever reason,
You got into a knife fight with your friend.
Yeah.
Good question.
And
they do
I go in and I'm intoxicated, and they do a whole workup. Are you going to pay for that if they had one 2 months ago?
I would think yes.
Then why wouldn't you in jail?
Good question.
So that's
good question. Very good question.
Okay, so you would. So maybe then it's not.
I mean, I
such an
think.
issue.
Well, that's place of service. That's place of service. That's place of service.
And that is a place of service.
That's a place of service. So you're paying for that because it's a place of service issue, and you don't.
And we also have all sorts of, you know, ER diversion programs.
That's correct.
Sure. So then I don't know.
But again,
I mean,
We'd
hopefully
love to have more jail.
I'm sure you would. I'm sure that.
But Kathy,
yes, exactly.
I want to go back.
I don't know the answer.
I'm going back to our population. See, I think that part of the challenge is that we don't have a lot of experience within this frame dealing with this population. So we don't see, there are not a lot of plan members that are 26-year-old heroin addicts that have a series of priors, okay, who have been on and off of heroin since they're 16 years old, who are reasonably beat up physically, and even if they've had an H&P within the past 2 or 3 months, as Dr. Barton says, he doesn't know what their state is. He doesn't know what they've done in the past 2 to 3 months. So he's going to want to see it.
In New York, I would actually beg to differ, and I think while there's not been Medicaid in the jails, New York has been covering childless adults.
Absolutely.
Since the beginning of time, because that's what the Constitution requires.
Right.
And the Family Health Plus program has been covering them since 2001. So there actually probably is a way, if anyone could share information on who's on Medicaid and who's in the jails, and I'm not sure that they can. HRA definitely would have.
Right, you have that data, and I think what you're still seeing is those heroin addicts that are walking into Rikers, even though they might be eligible for childless adult insurance, they still haven't been to a doctor since their junior high school physical the last time they were in Rikers. I mean, isn't that what you guys are seeing?
Right, we're their primary care physicians.
Right, so again, what I'm saying is even though you have that expansion, up until now, what you have is the jail has been their de facto PCP.
Yeah, I mean, one thing that we know and are putting out some papers to demonstrate this is for New York City's jail population, Medicaid or not, their health status improves while they're in jail because we give them a whole bunch of health care while they're there, and so their diabetes is under control, their substance abuse is under control. We get them
Right. So what I'm trying to point out, and I want to just try and go back to this, is to say we talked about again the Massachusetts data: 22% of substance abusing young adults are uninsured. That even if you are insured, generally speaking, you don't have a PCP if you fit in this cohort. Warrants, detainers, child support. Your job is to run from any authority figure that you're going to get near because you're afraid you're going to get picked up and put back in jail. These are our high-cost, high-risk patients, population-based plans, capitation. The whole world spins when we get to 2014 and think about this operationally. And I think our experience with childless adult expansions, I think we're seeing part of this now as we unfold in California, the way Pat talked about it before, is there's really not a good mesh. Yes.
Well, the other thing, you're absolutely right. And then there's the question is, are health homes going to solve that problem to some extent? Because one could argue that's essentially why these are being tried, right? Is to take this expensive, very sick population that doesn't generally seek care and put someone in a position where they're accountable for their care.
And as you know, we're working to make reincarceration rates one of the metrics for health homes, okay? And assuming we are successful in making that a metric for health home, then our expectation at COCHS is yes, then health homes will perform that function because I've created what I would say is probably the only viable accountability measure for how to improve the health status of this population, which is whether they're back in jail or not. That's what we know. I think part of what we're trying to tease out here, and I think is really helpful as all these conversations have been for these 2 days, going back to UR and QA, is what a lousy fit. I just want to make it really clear. What a lousy fit. We don't have a good way of our process of going through that stack. Ed, I loved your metaphor of going through that stack. We don't have a process way of having that conform to the expectation standards, and we have only briefly touched on the report card question. And to me, the report card question is the elephant under the table, because I'm going to flunk the report card on board-certified practitioners, okay? Even if I'm in New York, I bet I'm going to flunk the report card on periodicity of preventive health measures, okay? And that all of these report cards that we're generating, this population at this point within a managed care context is going to cause your grades, Kathy, to go down. Your membership is philosophically committed to serving this population. That's who your membership is philosophically committed to serving. But you don't want to risk your grade. I just want to put it out front on the table. You don't want to risk your grade as consumers go ahead and choose what health plan to get. You don't want your grade to be much lower than your competitions in the Medicaid plan because you're philosophically committed to this population. And so we have still another conundrum that I don't want us to simply let that elephant sit under the table. I want to bring it out. Donna.
Another spin here. So, you know these people. This heroin addict that we're talking about, you're going to have them for 14 days, maybe. More than 2 days, maybe a couple weeks. So you're going to have data on that person's current condition, and that person's going to have a treatment plan. That plan really needs that information so that the transition can be seamless and the guy doesn't fall into the black hole again. So that's a different arrangement than you getting punished by their bad report card. This is an arrangement where you save money by not losing that person to 5 more ER visits because you know they're coming out of jail and what their drugs, that the guy's got being treated for pneumonia and whatever. So there's a link there that gives you a ton of power.
But in COCHS speak, Donna, what that is that's jail as eligibility and enrollment, that's jail as an HIT site, and that's jail as handing off on discharge. That's not jail as a place of billing for pending disposition. So what I'm saying is a different paradigm.
It is, but if that relationship is beneficial to the health plan needs to build and keep that relationship. So there may be economic opportunities other than strictly billing for Medicaid services.
But that goes back to Ms. Gilmore. Pat, what were you going to say?
Well, I was going to say, again, yesterday what we talked about was if the health plans came to you guys and said, we were going to give you a subcapitation on all these individuals. In other words, we're going to pay you per head, and we might give you a little bit less rate, but we're going to give that to you guys, and then you guys could become responsible for managing that inside the jail. We have to have a different set of standards there and what's expected. But what I would say is, in a lot of ways, because of the frequency that these individuals are back in their jail, aren't they the health home?
Well, we're getting, so again...
I mean, in a lot of ways they are.
Or maybe they pay you $100 for every handoff.
Yeah, and so like yesterday we even talked about that. Maybe the counties or the city never relinquishes control of these people, because what you guys have done is you've married a public health model with the corrections model. The reason you're doing this is because you're trying to prevent the spread of STDs, tuberculosis, all those kinds of things. And you're trying to provide primary care for this population that's very expensive, keeping them out of the emergency departments. I would say you're doing a wonderful job of probably decreasing costs already.
But Pat, the question becomes, whose resources? I want to go back to the resource question.
Medicaid.
So what Maeghan started with, and if Paul were here, he would have given a more aggressive presentation on it, is the perspective of counties that shouldn't be a county resource, that should be a federal dollar through the Medicaid program that pays for that.
I don't know, Steve. Let's see, because think about this. Okay, first 3 years in expansion, 100% federal, and then the least it goes to is 90-10.
Right.
It's not county money anyway.
It's county money, and so
it's not county money for that, right?
I think the counties are going to say, and the city would say, you know what, we're already spending more than that right now. It would be a much better deal for us to always hold on to these people and have them be our responsibility, because we know it's going to save money in the long run anyway.
So are you suggesting then that the Department of Health becomes a managed care plan in which their detainees could choose?
Well, but on the behavioral health side in New York City now is carved out to Optum Health. So both the mental health and the substance abuse are going to be at Optum Health. So you could have one. So what I would say for that service, you work a deal out with Optum Health to get a subcap on that for inside the jail. Then we look at a whole variety of different standards for what services are being provided. Now, I'm not touching the physical health side. I'm touching the behavioral health side. And we go for that. Then we go back and we look at everything we talked about yesterday, different set of standards, different set of reporting, different level of utilization, really good quality assurance, that kind of thing, because they're getting subcapped already.
Why wouldn't the plan say to us, you guys are already doing that, why would we pay you for it?
Because your folks are eligible now for Medicaid, and they're getting paid those covered lives already.
They're eligible today.
And in New York.
And we already continue their eligibility today, unless we suspend them, but they have to be there past 30 days.
Yeah, so for us, at least in New York, for most of our the Medicaid expansion doesn't do much for us.
Doesn't do much for you guys.
So
right?
for the plans in New York,
But the exchange does.
Yes.
yes.
Well, it does some. It goes from 133 to 1.
That's
Yeah.
a huge.
I mean, it does all the rest. So the
Yeah.
exchange does a big,
But for the rest of it, it's a big deal because we
which
don't
is
have that.
which is going to be a very different set of insurance companies too. They're not necessarily all going to be interested from a safety net perspective.
Yeah, you can't bill where they're in the jail, can you? Can you
No.
bill for the medical
Just when they go
services?
to the hospital.
Yeah, see, the point, see in
Right now.
2014, you can bill your plan for those services.
But
Well, that's
only,
what I'm
Pre-trial.
asking.
but wait, but only if I can meet the plan requirements. So this is, this is how we started this, guys, okay? We can't believe we got this language through PPACA that the Fed is going to write everybody, every jurisdiction in the United States a check and say, okay, now we're covering your pending disposition individuals. That's not how the system works. The system says you have a qualified provider. You bill on a 1500 with a CPT code and an ICD-9. You have a processes for going through the stack that someone has reviewed and signed off on. You have metrics that get taken into the report card. It is not simply because they're pending disposition that you get paid. I've got to bill, I've got to climb that hill, and that's what I'm keep wanting to focus on is that hill.
Unless you are.
It's a public system somehow, and don't privatize it. It can work.
I mean, I think
Right, you don't-
A curve up.
Current system.
And if a sophisticated jail like New York's can approach the plans that are going to be selling on the exchange and say, you know what, we have your scariest new members. They will fall all over themselves.
Yes.
Commercial plans don't know anything about these people.
But here's what I think here's what I think commercial plans will say, because if you're going to be in, and we did have some of this conversation earlier today, if you're going to be incarcerated for 9 months, chances are that your income is going to go back to Medicaid levels. So even if you were covered by a qualified health plan in the exchange, because you were making 225% of the poverty level, you may not have been doing that, but even if you were, chances are you're going to go down to the Medicaid side. So I would think that,
The Medicaid health plans don't know this population either.
well,
They know moms and babies, and they know ABD.
She's a Medicaid health plan, yes. She's a
Not-
Cap one Medicaid health plan.
Medicaid health plans know a fair proportion of these people, but clearly not all of them because they're not on Medicaid as much. But some of them are.
Relationship between the two
I mean,
organizations.
in New York, substance abuse is a covered service, so it gets paid for. So a lot of people end up on Medicaid to get substance abuse and get mental health coverage.
Well,
But if the jails can look at themselves differently and then having a natural affinity to the Medicaid health plans and the new commercial exchange plans and bringing valuable resources, it's a game changer.
yes, but
And
those
I don't think
resources, but Donna, what I'm saying is those resources still require systems.
They
that-
don't. They might. They don't have to.
We have to argue they don't.
Flo?
They
were you
don't
saying-
have
wanting
to.
to say something?
I just have a question. I wanted to go back. Where is the process of getting reincarceration rates as a metric? Where is that going on?
So in New York State right now, for health homes, COCHS has been working very closely with the state Medicaid agency through the offices of Governor Cuomo in defining what the metrics that the health homes will be judged on. And the governor has more or less politely asked the Medicaid agency to add a reincarceration rate as one of the metrics in which the health homes will be judged. From where we sit at COCHS, this is a tremendous game changer because what it does is, in my language, I medicalize the criminal justice system and I acknowledge that most of the people who are in jail are there because of underlying behavioral health disorders, and I am making an expectation overt that the healthcare system treats those behavioral health disorders to the point that that individual does not find themselves reincarcerated. I want to go back to one thing I think I heard you say, Cynthia, which is Medicaid expansion in New York hasn't meant very much for you. And I'm wondering if you could amplify that statement a little bit, because if I were listening to most of the folks around this table, I think what they would have said, well, Medicaid expansion in New York presages January 1st, 2014, and it should have meant a lot for you. So why hasn't it?
No, I wouldn't say it hasn't meant a lot to us. I'm just saying that the expansion via the ACA doesn't...
Let's go back to the Medicaid expansion. What has that meant for you concretely? What is having expanded Medicaid for childless adults, substance abuse coverage in New York, what has that meant in terms of the patient population that walks through your doors?
In the jail system? I mean, I would say... we've looked at this before. I would say 70% of our population at the minimum is eligible for or on Medicaid.
So it means when they get released prior to 30 days, if they're on active Medicaid, they continue to have those services on the day of discharge.
That's not my question. My question is, if 70% are eligible or on Medicaid and they're showing up at Rikers for criminal conduct that's related to a behavioral health disorder, something's not working right.
Oh, correct. Absolutely. I mean, I think you're right, because as we talked about, these folks are not seeking care on their own in the community, and so they do show up with us, and it hasn't meant anything to us in terms of an improved health outcome.
Right.
Except that it gets us better tools to try with our limited resources to better connect them to care and enable them to be ready for care when they're back out in the community.
Yeah.
And I would caveat, a lot of New York City's work around Medicaid, a lot of it in jail, has been focused on the mentally ill because we're stipulated to do so.
Right.
So the one thing the expansion might do is create the need to facilitate enrollment for a larger portion that has already been eligible, but we hadn't been working on Medicaid applications for. So, and I was going to get back to the reincarceration rate for the health home. I think that people's behavioral situation and underlying substance use and mental illness often brings them to jail, but I think it's much broader than that.
I agree.
I mean, I think people's inability to get housing, employment, all that stuff. So the health homes, I was asking Cindy on a piece of paper, because she knows more about them than I do, whether they're also responsible, the care coordinators, for managing people's housing needs, employment needs.
Yes.
Okay.
Yes, the answer is yes. I want to, before we break, because I have to be sensitive to Megan's time, before we break, I want to just speak briefly, Cynthia, to what I heard you just say. Because when I'm here in D.C., and I go to these public policy meetings, what I hear folks saying is, come 2014 and come parity, because we're going to have substance abuse coverage and we're going to have eligibility for all these individuals who are now being incarcerated because of behavioral health disorders. It's going to be a whole different game, okay? And you need to think, Rosenberg, about this in totally different terms. And I say, well, maybe. And the reason I say, well, maybe, is I think about your experience in New York, and your census didn't go down a whole lot when I provided substance abuse services for childless adults. Your census didn't go down a whole lot when I provided Medicaid expansion for childless adults. Yeah.
I don't know if you can even, New York State's been providing substance abuse services since...
That's just under Medicaid.
Under Medicaid. Well, and just without Medicaid for a smaller population.
For a long time.
For a long time. So I don't know how you could... I don't know how you look at it.
Because Medicaid as a payer, in theory, if I go back to my theory of 2014, that Medicaid as a payer is perceived that it will change the ground rules. This is why everybody fought so hard for parity. That rather than having a grant-funded program or state-only funded, the perception was that having a Medicaid-funded program with parity for these folks would be a game changer in terms of how we think.
Certainly, I think it certainly changes some of the funding paradigms, but I don't think, it hasn't eliminated waiting lists and those kinds of issues.
Yes,
you have to seek treatment.
Hold on, you just said my magic words, okay? Which is this population. This is where everybody's got to understand who these folks are. This population is not a TANF population. This population does not seek treatment. This population is reluctant to get into treatment, and that creates an entirely different paradigm. Flo, and then Pat, and then Cynthia.
I just want to agree with you because all the actuarial studies of how people seek substance abuse treatment, regardless of payer, because for years the substance abuse providers themselves said the reason they don't seek treatment is because nobody pays for it. Well, it turns out that isn't true. Even when there is a payer, they will not seek treatment. So it has a negative demand curve, unlike almost every other part of healthcare. So you have to do something different to get them in and to keep them in.
Get to rock. I mean, people get to rock bottom and then they.
Okay, Pat and then Cynthia.
This is really, though, I mean, let's keep sight of this. This is the pig in the python right now, right?
It is a pig.
Okay, so what we've got to do is we've got this great big pent-up demand right now that we've got to take care of. And it's a tough nut to crack. There's no question about it, but we've got to do it. But what we've got to start to do is get upstream now. The kids of these people, we've got to start to get them integrated into the primary care right away. That is our best hope of maybe 15 years from now of really starting to get that digested inside that snake in reasonable bites. So, yeah, we've got to be able to do this, but that's going to be the goals. We've got to be thinking down the road. So prevention, intervention services for families and younger people has got to really be part of this.
Cynthia, you've been patient.
Well, and I think, the big test, I think New York is a good place for us all to look at that as well. We've had the expanded Medicaid for a long time. What we haven't had is the overlay of the care coordination models, like what health homes are doing. And let's see what happens to demand for this population when we have someone who's saying, look, I'm going to take you and help you through the housing process so that you're in a better place there and you're not living on the street, and I'm going to help you. I'm going to take you over here, and when you don't show up to your appointment, I'm going to come find you, and I'm going to do this. And I think we all want to hope there are a lot of eggs in that basket that is going to work. I think we actually don't know the answer yet.
But Cynthia, health homes are supposed to end in 2014.
No.
They're
Well,
not
90% federal funding is
Right.
supposed to end
And
2
it's
years after your
Right.
after
Fine.
a state's
Okay, let's be
health
more
home
accurate.
state
Right.
plan has been approved and implemented.
Right.
That's different
So
than 2014.
The federal funding for health homes is supposed to end.
Enhanced
Federal funding. Okay, fine.
No, it's a very important.
Yeah.
Right.
To me, it seems absolutely outrageous that we're going to demonstrate cost savings
And then they're
to
gonna
the
take
point
them
where
anyway.
we can pick up the rest of the bill in 2 years.
Right. Right.
But-
And that's, you're going where
That
I was
wasn't
going.
my choice.
Right. That's exactly what I was going to say.
Yeah.
It was 2 years
And
more
so-
than probably anyone thought they was going to get.
Right, and so I think this just raises still another public policy conundrum, right? That the enhanced staff map
Yes.
ends in 2 years. I'm expecting the state to pick up the rest of the bill. Do I really think in 2 years' worth of data, I'll have sufficient data to justify the state picking up the rest of that bill?
Everyone's hoping so.
Yeah, but what do we really think? It's my question, and so I think these are great discussions that we've been having, and I appreciate them, and I need some feedback from you all. So clearly, on yesterday's conversations on eligibility and providers, there's more work for the working groups to do, and we will definitely be reconvening in February. I think the question I have is on these issues of billing medical records and QA and UR. Is there more work for these working groups to do, or all we have to say is this is a steep hill and we need to think about how to climb on it, and is it worth engaging in another set of discussions on these two issues we talked to today? I don't have a horse in that race. I would appreciate feedback.
What I would say is, I talked to Maeghan at lunch on this, and my feeling on this is, Steve, is that I thought I had a pretty good grasp of this before I came here yesterday, and now I realize I don't. And I've got a list of stuff here that I've got to go back and talk with my sheriff and my elected officials about. So, and I think I have a pretty good understanding of this. I think what we have to do is take baby steps on this thing. And what I would say is let's keep the bigger issues out there, but let's not dump those on the NACO staff to have to dump on the elected officials at the national level, because you're just going to scare them away. So let's do the things that we know we can do.
Okay.
Okay, so that's my recommendation. Because like somebody said this morning, we don't have to do this in 2014. We can just, it's a process,
Okay, so here's a management decision I would like to make if I don't have strong objection. The management decision I would like to make is let us plan on February 23rd, and Maeghan will get back to us with times and everything else. If we feel at the end of that discussion that there's more discussion we want to have, we will adjourn the meeting, and Megan, you'll give people's times on the 24th. You'll ask them to hold their calendar on. But we will recognize that we may or may not need that time on the 24th. Does that seem like a reasonable way for everyone to handle that? Yep. They're not, so we're doing them here. I think Megan will invite locals who wish to come up in person. I think, Megan, if you would put that in your invitation. I heard Kathy just raise her hand, and that was the question.
No, that wasn't.
Okay, I'm sorry. What's the question?
My question was, since not everybody was at all the different sessions, if there are a bunch of or minutes or overarching questions.
Yeah, it's all recorded. So there's two things. So
I
one,
know, that's hard, but
it's
that's
hard.
really hard to do.
It's hard to do. And then I think, Megan, do you want to send out?
I don't think it's going to be done.
Do you want to send out notes?
Yeah, I think we are going to send out notes. The other thing is, I think moving forward, most people have participated in all four. I think if you want to participate in
You've got
the
to
others,
sign up for all of them.
Yeah, I just
Right.
think if you know, because we keep going back to some conversations we've had earlier, and so since we'll be doing this WebEx, I think it'll be easier for people to put that time in.
Just a thought. I wonder if it might be a good use of time for the people in this group that are the jails to hear from the plans about what the plans think they would want from jails.
Donna, you're great. I was thinking that was our April meeting in my mind, that we needed to get our way through these, what I would call mutual familiarization with each other's issues.
Yeah.
But I think in terms of the goal and where we're coming from, I really appreciate your anticipating exactly where I was going. And that's why we've asked John and Kathy to participate, is I think that we need everybody needs to hear from each other where their starting point is. COCHS' experience in general is that we bring together folks from very diverse silos who really don't understand how each other's silos are organized. And it takes a while to get mutual familiarization with the general vocabulary and territory of everybody's silos before we can, in these small working groups, actually move on to problem solving.
Well, and in doing so, I think you also need to be willing to let go of a rigid expectation that jails have to bill on HCFA forms and meet credentialing criteria, because there might be something far more flexible than that.
Well, I think this goes back to what we asked Allison this morning on the issue on I think there's several, so let's just delineate for everybody's understanding. Let me go through my version of the possibilities. There's new provider type, which we've talked about yesterday and this morning. There's sub-capitation agreements, which create a whole different way of thinking about this terrain. And there's a more traditional Medicaid, 1,500, et cetera, way of thinking about it. I think
there might be other things, though, too.
Give me other possibilities.
Yeah, maybe there's just something we didn't think of, like, they'll trade groceries or something. I mean, we could just be off the chart with something.
There's a swap meet I haven't discovered yet.
Yeah,
I always like that possibility.
$100 per jail discharge if you give us the medical who knows?
Right,
but
okay.
Don't put yourself in a
Fine.
box
So
yet.
there's a fourth possibility I haven't thought of yet. I love that. There's a swap meet. Let's call it my swap meet possibility. I love that metaphor. Okay. So I think that's great. I think that before we can really go through that, part of what I've wanted to do in the past 2 days, which is what you've heard me do, is I've wanted to hold up the traditional Medicaid paradigm as a straw dog. And I've wanted to hold up the traditional Medicaid paradigm as a straw dog because I think it's really helpful for everybody to understand how far away jails are from that straw dog. And I think that as we progress, I'm hopeful, Donna, that we're going to get exactly to where you're going with this conversation, which is if the answer is we can't really fit this round peg into this square hole and we recognize there's a mutuality of a win-win in this, what other kinds of financial, service, reporting, information, relationships can we develop that allow for that? And again, from where COCHS sits, this reincarceration rate in the New York State health home paradigm is the very first step in trying to figure that out. Because I now have a health home that's got 90% federal dollars to run a bunch of science experiments on what it takes for them to meet their metrics of a lower incarceration rate. And what's going to be really interesting to watch is how do those health homes even think about doing this? What strategies do they develop within their own place, in their own space, where they're not bound by 1500s and any of these other stuff? They're free agents, if you guys understand what I'm saying. What strategies do they develop to try to go ahead and meet that metric? And that's why we, at COCHS, we put so much time and energy into working with Governor Cuomo's staff and Mayor Bloomberg's staff to try to persuade everyone on the importance of doing this. Because I think this, in my mind, this is my first trial run down the track in thinking about this. And it'll be very interesting. You know, the other thing we're waiting for is we're waiting for Greg to define the metric. So Allison and I advanced one set of metrics that should be used for the health home. I think Trish's staff at New York City Medicaid advanced another set of metrics. I don't have a horse in the race. We won't know until the actual metric is out there what we're using for that, and that may impact how health homes proceed, if you all understand what I'm saying. So with that, I want to again thank Spark Street Digital. I want to thank NACO. I want to thank my staff, particularly Nan Torrey, for all the work that she's done with Maeghan in putting this together. And Maeghan, I obviously want to again thank NACO for hosting this and for all the help you've given COCHS in helping us think through. I think Paul said it this morning that we've done more thinking than any one person should have about this, and we obviously have, and we appreciate all of your help and all of your input in stimulating our thinking when we go back to the office and we sort this out amongst ourselves on what others. And Donna, I like your swap meet one. I'm going to hold on to that one.
We appreciate all of you for kind of slogging through the last couple of days. Anita and I really have put this together with COCHS, so let us know if you have questions, and we look forward to continuing conversations. I don't know if we've answered any, but we certainly have more questions. So we'll see what comes of this. So.
And Pat, I really appreciate your saying that you thought because you are probably, as the counties go, you're my resident expert, right?
Oh, geez.
You are.
We're really in trouble.
You're my resident expert, right? That's why I dragged you to that other meeting in D.C., because you were my resident expert.
Well, I'm impressed with your stamina, Steve.
So is my staff. Thank you all very much.